This conference will now be recorded.
So good evening, everybody. It is March the 31st, which is not exactly a first Monday, but close. And the reason why it's close is because in the month of April, first Mondays and second Tuesdays follow on successive nights. And as much as you love us, we know you don't want two meetings in two successive nights. So that's why there is a change, and it will be in effect the whole of the month. We will still have two meetings on Mondays and two meetings on Tuesdays. They won't just quite be where you expect them to be. So a quick thank you to our sponsors, Bayer, Novartis, Johnson & Johnson, Myriad, Foundation Medicine, Telix, and Blue Earth. There's things going on every day with these sponsors. Just today, our Myriad sponsor resigned after 3.5 years, so I don't know who we're going to be seeing next, but she wrote something very nice in LinkedIn, which was very sweet of her. Before we get going today, I got a couple of things I did want to talk about. In no particular order, I missed this on Thursday, although I don't expect Len did, and I doubt that John did, and a few others of you. But CDMRP, the budget was cut, I don't know whether it was the budget or the programs because Alexa wasn't sure, but they were cut by 60%. So there are a lot of conditions, some of which we serve, like multiple sclerosis and sarcoidosis, that have been cut out completely, and others have been cut back. So there will still be a prostate spore or whatever you call it this year. I don't know how big it'll be. I've got no idea.
75 million for prostate this year.
So it's going to be 75 million for prostate this year from, what was it last year, John? 110?
Yeah, it was something over 100, but I can't remember what.
Okay. Does everybody know what the CDMRP is or does? No. Okay. So congressionally directed medical research program. How's that, John?
I don't know. I think it's right. I thought the word mandated was in there somewhere. No?
Okay.
Oh, you got it, Rick. Spot on.
Okay.
Congressionally directed.
Yeah, I'm looking it up too. It's medical.
Okay. So and we have a number of reviewers here tonight, and AnCan boasts probably somewhere around 10 to 15 reviewers, most of them prostate, but we have some people in other groups. So for example, Alexa is a rare disease reviewer. And this is a budget mandated by Congress and distributed through the Department of Defense. And projects are submitted and they're reviewed both by scientists and by patient peers. And the science can be very complicated. It doesn't necessarily have to be, but it often is. There's all kinds of new and fancy ideas that come through. It's all somewhat secretive in the sense that the reviewers can't talk about the research that they're doing. Len has been a reviewer longer than I care to think about, and John soon after Len, but not as early as Len. And they are reviewed they are reviewers for the prostate cancer projects. Traditionally, I think the most we ever got was $120 million, whereas the most that breast got was about $150 or $160 million. It was gradually going up. I think we had 110 million last year, and now these budgets have been absolutely slashed, and there's some pretty good research that goes on. So that's what the CDMRP program is. It's administered by General Dynamics. If one wants to be I don't know about now, but in the past, if you wanted to be a reviewer, it was a fairly rigorous process. You had to be recommended and interviewed and goodness knows what. So let me just, since we have the time tonight, let me just throw it out to John and to Len if they'd like to say anything more about the CDMRP program.
Go ahead, John.
Okay. This program has been fantastic. A great many of the things that have helped us deal with our prostate cancer can trace their early beginnings back to the CDMRP prostate research program. It's under the military budget. That's probably why it didn't get cut out altogether this year. I don't really know. But it's a wonderful program and a source of funding, and they're very rigorous, and I'm really glad that they didn't get demolished this year.
Thanks.
Also, I just put a message to everyone. I do a lot of the liaison between AnCan and this program, and if you're currently a reviewer, I just would like to know who you are.
Oh, Doug DuFresne's another one. We can add Doug DuFresne. How about that? Who knew? Good job, Doug. So
can I interject just to say another one of our facilitators, Ben Nathanson, is also a reviewer?
Well, like I said, we have about anywhere between 11 to 15, I think, in total. I have them all tagged in my notes, but yes, Ben is a reviewer. There are several. If we ask John, since he has nominated a whole bunch of them, he can probably tell you who some of the other ones are. But let me, Len, I'll come to you after. But you have your hand up, Doug. What would you like to share?
As it turns out, I found AnCan as a reviewer
Right.
for CDMRP. I was referred by Zero, but in our initial introductions, we said who had recommended us, and a couple of people mentioned AnCan. I had never heard of you, and that's what led me here.
Oh, okay. Len, anything you'd like to say?
Well, I would just say that the patient is considered a consumer reviewer. They are not responsible for understanding the science, and we are told that we are to assume that the science is correct and valid. The consumer reviewer's role is to determine or to inform the scientists how relevant this particular research might be for the prostate cancer patient. Do you agree with that, John?
Yeah.
Even if you don't understand the science.
Yeah.
It does help, however.
I've looked at, I have an idea. I've never actually looked, but I have an idea of some of those papers, and that science is pretty mind-boggling. It would certainly beat me. Gary V in Portland put something in here that the cut for 2025 was 57% of the 2024 budget, from 1509 to 650. But that math doesn't add up, because I did it roughly in my head and said to Alexa, "Oh, that's about 900 million," and she said, "Oh, I'm not really sure." So 1509 to 650 is a little more than a 30% cut. But just saying, I heard that they cut the budget by 30%, or you say 33%. So that would give us about 9 billion plus or minus. So I'm not really sure, but that's the budget for everybody, and we know what's happened to the prostate cancer budget. So, all right, guys, that's the first thing I wanted to talk about. The second thing I wanted to talk about was some breaking news that I didn't get into the reminder on Friday, which I'm sure many of you have already heard, which is that Pluvicto was approved for men with metastatic castrate-resistant prostate cancer before chemotherapy. And that makes a big difference for a lot of people. Dr. Sartor estimated it would triple the demand. I'm not quite sure about that. The other big issue, which I'm really not sure about, even though I've read a couple of things already, is how exactly they're going to define metastatic castrate-resistant prostate cancer. And I actually think that there will be some type of panel that may decide whether you are or you're not a blinded BICR type of panel. I don't know, and we'll just have to see what exactly it means and how that pans out. So there you go. It's a good thing. It's something we've been expecting for a long time. There were some glitches in the PSMA4 trial that had it going around in circles and chasing its tail to satisfy the FDA. But evidently they did satisfy the FDA last Friday. And, my gut tells me that the earlier you get this, the better it's going to be. Something that definitely has come out in terms of the discussions we have offline with the Brains Trust is that the Telix trial, which is also pre-chemo, probably has a worse side effect profile. But at the same time, I don't think that story is necessarily over, because they can deliver their dose in 2 weeks, start to finish. And the dose with Pluvicto takes about 36 weeks. And my feeling is that we may see, and it's something I actually tried to call you, John, because I wanted to talk this out with you today. But we may put a little pressure on Telix and say, guys, why are you offering this dose design when it's relative? It has pretty significant AEs, adverse events. It's a lot more than the Pluvicto. So this is, guys, please do not send me long messages when I am moderating. When exactly do you think I'm going to read them? Any ideas?
That's kind of what Len and I are here for, is to back up the moderator. So you're welcome to send anything to all organizers or to Len or to
I don't know
me.
when you think I'm going to read it. Can you use your noggins. Use your noodles a little bit.
I've heard you say that before, Rick, and I appreciate that. And I'm sorry. It's just, I just thought it would go through as another email to be read at some other time, and I apologize for that.
Well, the thing is that we try to keep our eye on the chat window because there are important things that come up and people have questions. So, we're juggling balls, and when somebody sends something, my eye goes to it immediately. I'm afraid I'm not going to be able to read it. I don't even know if I will try to download it and look at it later, or better still, send me, cut and paste it, put it in an email, and send it to rd@ancan.org. But this doesn't just go for me. Please give some consideration to the moderators that there's only so much we can all do at the same time. All right, now let's get on with Mr. Postal, and who I have seen in several other groups. And I sort of vaguely remember his story, but we will run through it. And I'll, by the way, with this Pluvicto issue, my guess is it's probably going to be a couple of months before the insurance is ready, but it may be quicker. But there are some education materials coming through from Novartis. They sent me a note today. I don't know what they'll be like. I don't think it's going to make a huge difference for this group because we're already pretty familiar with Pluvicto. And we have, better than being familiar, we have peers who have had great experience with it or experience with it. So, but you should all be aware that it could be an option and you don't have to go through chemotherapy first. All right, David Postal. How do I pronounce your last name? I've tried Postal.
Postal.
Okay.
Postal Service.
It's like in the service. I'm going to ask you a bunch of questions and then we'll get to where you're at. How old are you, David?
78.
And where do you live?
Scottsdale, Arizona.
Right. And what year were you first diagnosed?
Well, it depends. When you're speaking of bladder cancer, I've had bladder cancer, so that's where the journey started.
No, when were you first diagnosed with prostate cancer?
2013 technically. It was a 3-3. I had several biopsies prior to that, but they didn't find anything. Okay,
so in 2013 they found something with a 3+3. Correct?
At Mayo.
And what was your PSA level at that time?
About 1.5, 2.
Okay.
From 0.8. It's been 0.1 to 0.8 for probably 10 years.
Okay. And then when this was back in 2013, and you were in the care of a urologist, I assume, probably the guy that was looking after your bladder.
No, actually someone else. I moved. I had Guberic, which is community urology associates, and I was also going to Mayo.
Okay. So why don't you tell us how your disease progressed from 2013 quickly, rapidly tell us how we get up to 2025 where you feel that you now have not metastatic, but high risk disease.
Sure. 2013, I've been on active surveillance until about last year, actually, 2024 early, they did another biopsy and I was at 3.4, went from 3.4 at Mayo, Actually, that was with another group. Then I went over to Mayo, and they wanted to have another one done in January, another biopsy done in January. And at that point, I went to 4-4. PSA, at that point, it moved from 2.5 to about 4. Depending on which PSA you take. I was at 3.5 to 4.5 in January of this year.
Okay. So right now, as we stand, you believe that you're a 4+4 and your PSA is somewhere around 4.5. Is that correct?
Yeah, 3.5 to 4.5, which one you look at.
Okay. What is the Mayo reading?
Well, there was Sonora Quest. Now, if you know Sonora Quest, Mayo was 4.5. Sonora Quest was 3.5. Both done within a week, within a week of each other.
Okay. What result did Mayo give you?
4.5.
Thank you. Now, have you had these biopsy slides reread?
No.
Okay.
You did tell me about Epstein, the last couple things, and I sent it in to Epstein, but I haven't heard back from those guys.
Okay, so have you actually sent your slides to Epstein for a reread?
No, I talked to them, they were gonna get them from Mayo, and I haven't heard from them.
Okay, well, you need to chase them up, and if you're not getting satisfaction with Dr. Epstein, go to Dr. Zhu.
Yeah.
But the first thing you need to do is to get those slides reread.
Yes.
Okay. Second question, have you had any scans?
Yeah. PET scan.
What type of PET scan?
PET scan January of 20. The same thing after the biopsy and a couple of MRIs. I had a PET scan, and that was in January 25, and it's clear.
Was that a PSMA PET scan?
Yes.
Okay. And it's clean, correct?
Yes. Correct.
Okay. With your bladder cancer, did you ever have your tumor sequenced?
I don't know what that means.
Okay. Did they ever take a sample of your bladder cancer and analyze it for mutations?
I don't know, Rick. I don't know. It was all internalized. I did the BCG, rolled around in the BCG, and they pretty much got rid of it. Then I did mitomycin, if you're familiar with that stuff, mitomycin. It recurred one time, and they blasted it and got rid of it.
Okay, so as far as you know, you've never had any next generation sequencing?
No, don't know.
And have you ever had a germline sequencing to see if you've inherited anything?
I've done some of the DNA testing with a couple of these groups, and it was a little inconclusive. I didn't understand it, but I have some results from that, from DNA stuff.
Okay, so who got you was this ordered through your doc, or was it ordered through you?
Through the doc. One of my docs, my primary care doc.
Okay, and did they tell you had any inherited cancers?
No, they said they didn't, but.
Okay, so no germline.
No,
so right now, who is your urologist who's your urological oncologist at Mayo?
Well, I've talked to several people. Frendel is my urologist. I've talked to when 2023, when I went to 3-4, I began looking at treatments. Left active surveillance and started looking at treatments. And so I've been talking to a number. My local doctor is Dr. Guberic, and he's on his own. And then a Mayo is Frendel. So I started talking to them, and I talked to their prostate.
And who's going to guide you in this treatment? Are you going to go to your local community doctor, or are you going to go to Mayo?
Well, I've been to both of them, but I'll run through that. I've got Mayo. Mayo talked to me about prostatectomy and radiation, IMRT. They were going to do 15 IMRTs and with some ADT to be determined. I first started off, well, I first started off with, when I was first diagnosed with it's 7 in the middle of 2024, I started pursuing Tulsa. Tulsa because, as you all know, side
Okay,
effects.
but we're beyond there. So let's not even go to Tulsa. So right now, you're 4+4, we think.
Yeah.
But we've got to get a second reading on those biopsy slides, and then based on that reading, we can decide what is help you decide what is the best course of action. If it were me, I'd stick with Dan Frendel. He's a good doc, and I don't consider him to be a cutter, so he's going to advise you to do radiation if right. I would say a guy of 78 probably shouldn't be, in my view. If it were me, I wouldn't be thinking about surgery at that age.
I'm not.
Because it's a very tough surgery.
Right.
But we can't even talk about hormone therapy or anything else until we have a confirmation on that biopsy reading. Was that 4+4 read by Mayo?
Yes, but I've also had UCLA look at it, and I think it's pretty accurate.
So why did you have UCLA look at it?
Because I'm talking to them about various options, brachytherapy. Dr. Chang and brachy.
Yeah, I know Albert well. So I think that one of the things you've got to do is settle. If it were me, I'd be settling on a quarterback.
Yeah.
Because we can be jumping from horse to horse here. You've got good docs at UCLA. You've got good docs at Mayo. And I think you've sort of got to decide where you're going to go first. But before we can decide that, we need a confirmation, and the confirmation from UCLA or from Mayo, or the readings from UCLA or Mayo, are not the same as getting a reading from Dr. Epstein or Dr. Zhao.
Okay.
So what questions do you have for us?
Well, I pretty much settled on UCLA and brachy. I've talked to several others. I think I have I did a Prostex, and so IMRT is pretty much out of the question. So I think brachy is. I looked at. I have a local doctor here, Dr. John Kressel, who's the SBRT guy. We were going to do high fractionated. We're going to do the five fractionated early on, but now that I've 8, he thinks that won't be applicable. So he would do, if I was going to do SBRT, he would do 3 SBRTs, say 15 IMRTs, and 6 to 12 months ADT. That's his plan. Brachy is kind of what I wanted to talk to you guys is UCLA. Brachy, Chang wants to do 2 brachy's in the same day with no ADT. And I haven't got that recommendation from pretty much anybody else. Mayo, UCLA, St. Louis. I've talked to St. Louis. I've talked to Texas. No one has suggested no ADT.
Well, there's a couple of things. Again, first of all, how many cores do you have that are positive?
Well, let's see here. Let's see, biopsy.
How many cores did they take in total?
Well, the last one was 14.
Okay. And how many of those were positive?
4, 4, 8. Cribiform in 1 lesion, otherwise 2 lesions at 4, and the rest are 3.
So how many lesions were positive?
1 cribiform and 2 4s and 2 3s.
So is that 4 or 5 out of 14?
5.
Okay, so 5 out of 14 were positive, right?
Right.
2 had 4. 2 had 4 in them. How much 4 was in the 2 4s?
I couldn't tell you offhand here. I have to go back and look.
That's important. You need to look and read through again. It's sort of important when you go talk to these guys. If you don't have a lot of four, you may have other options. Where are the positive lesions? What part of the prostate?
On the exterior, two on each lobe, on the bottom of each lobe.
Okay, so they're on the apex. They're in the apex of both.
Yeah.
They're both in the apex.
Yeah.
That's a good thing. And are they close to the edge of the gland?
Pretty close.
Okay. Look, I mean, first of all, doing 2 sessions within 24 hours is not unusual. They used to do them overnight. I don't know how Albert does it anymore. Albert was one of the first people to do them separate. He went from doing them 2 overnight, and then he did 2 a week apart, and now he's back to doing them 2 overnight again.
Yeah.
I think the bigger issue is if you're 4+4 and it's close to the edge, that you've got to get some second opinions on whether you need a treatment outside of the gland, whether you need IMRT.
Right.
And so in my own case, for example, I had brachytherapy seeds and IMRT. And a lot of times with men who have 4+4, it's a good idea to consider doing IMRT to avoid it coming back. So, and I'm sure that I'm not the only one on this call who's probably had IMRT plus brachytherapy. So, if Albert's saying, no, you don't need treatment outside, I would be getting a second opinion on that.
I am getting a second opinion actually from Rossi. Do you know Rossi in Glendale? Glenwood Springs?
I mean, the only Rossi I know is Carlo Rossi in San Diego.
Rossi is one of the, apparently there's Frank and Rossi and Chang. It's my understanding they're the good Breaky guys.
Well, are you talking about in Phoenix?
No, Frank in University of Texas. Rossi's
in Steve Frank. Yeah, I know Steve Frank. Oh my gosh, I know Steve. Yeah, I do. Of course, I know Steve Frank. Sat next to him one time, and so you're talking to Steve Frank.
Not talking to Steve Frank. Yeah, I'm talking to Rossi and Chang, and then I'm going to kind of talk.
There are a lot of good brachytherapy guys, but I would not. I don't know. I'm going to throw this open, and I think the first thing you've really got to do is get that second opinion, and then you've got to decide. Really, for me anyway, I would decide what type of treatment, because you can be running yourself all around the country here, and to see all kinds of different doctors. And yes, Steve Frank's great, and Albert Chang is great. The only Rossi I know is the guy that does proton beam. Is that the big guy you're talking about?
No, I don't think he's his. It's Peter Rossi.
I don't know him. Okay, so but I know Steve Frank at MDA, and I know Albert well, and he knows me. He knows AnCan. Guys, how would you advise? Hands up here. Who would like to give some navigation to David? Anybody?
I ask a little more about your Prostox report?
Sure.
Sometimes they'll sway a person from IMRT or to SBRT, or what did they advise you there?
SBRT was okay. IMRT could be dangerous. High risk on IMRT, low risk on SBRT.
Okay. Thank you.
Part of my issue, a side effect, is that I have a young fiance, and ADT would not be my chosen, my preferred method. So that's one issue. It's not the only issue, but
Yeah, Rick's got it. Len's got his hand up, Rick.
Yeah, go ahead, Len.
Is that me?
Yes, sir.
So one thing I'm a little confused at, David, is you had 4 or 5 positive lesions show up on the biopsy, and none of those showed up with the PSMA PET scan. Is that right?
well, I had the PSC. No, I guess I was thinking the PET scan was for outside the bladder. I mean, outside the prostate. I don't know if they showed up inside the prostate. I presume they must have. I don't know. It's a good question.
Okay.
I was thinking everyone's relying on the PET scan for the outside the bladder. I'm in the prostate.
Well, as far as we are aware, for prostate cancer patients, the PSMA PET scans typically go from the top of the head to the mid thigh or around
Yeah,
there.
yeah, you're right. Yeah, I know it's a good question. I'd ask that. Yeah, I would presume, I guess, Lynn, that it had to show up. I mean, right?
Well, it does and it doesn't. From
No.
what I understand, and I could be wrong, the SMA PET is not particularly definitive within the gland.
Yeah. Okay.
It's not it is really to determine if there's something outside the gland.
Yeah.
But PSMA PETs are not used to identify inside the gland. I mean, that's one of the reasons why we don't use them more extensively in low intermediate, because many prostate cells will express PSMA. Now, the more aggressive cells tend to express more PSMA, and you might get more of an image. But I don't think PSMA PETs are particularly definitive for inside the gland. That's my understanding, Len.
But David also said he had an MRI, I believe, and that didn't pick up anything either.
I don't know what he said about an MRI.
A couple MRIs, Lynn. Yeah. You mean did it pick up anything in the prostate? I think it must have. I don't know exactly because that's why they used that to define the whole thing.
And so you had BCG treatment for bladder cancer. There was no surgical removal of your bladder. Is that right?
No. Right.
That's it for me.
Okay, Richard Wasserson. You have to unmute, Richard.
Sorry about that. Okay, let me start again. You mentioned legitimate anxiety about loss of sexual functions or libido with ADT. This is where you might want to explore, although it's off-label, and I'll be talking perhaps a little bit later, the use of transdermal estradiol as opposed to drugs like Lupron, Eligard, Zolodex, etc. And there is preclinical, I don't know if this doesn't sound like, but background. What is that sound?
I got him.
Okay, thank you. So the transdermal estradiol, both in preclinical and in some clinical data, has been shown to preserve libido above full castrate level, not as well as if you're on testosterone, but you might want to explore that with your doctors.
It's called transdermal. What was it, Richard?
Estradiol. Well, I'll mention it later.
Okay, yeah, thank you.
All right. Anyone else who would like to offer some guidance or can relate to this from their own treatment?
Just one more question I have for David, Rick. How is your urinary function right now?
Well, not bad. I have a few a little leakage every once in a while, a few spurts, but stream is pretty good. Emptying is pretty good. I don't have any problem with that. You know, they always ask you, could you live with this the rest of your life? Yeah, I could. Yeah.
Okay, because I think we typically hear that if you have any urinary incontinence and then you have subsequent radiation, you kind of lock that in. Now, you sound like
I'm sorry, what was it? What kind of radiation you say there?
any kind.
Oh, ADN. Okay.
So that's something to discuss with your doctor. Maybe yours is so mild that that isn't going to be the case. And also, I've also heard that brachytherapy is has more urinary toxicity than IMRT or SBRT. And so if you've already got a urinary issue, brachy, that's another thing you need to talk to your doctor about, see if that's appropriate.
Okay. What was the there's some external sphincter issue as well. Have you heard of that from brachy or any radiation, I guess? It affects the sphincter. Can negatively affect the sphincter muscle.
I'll leave that to Dr. John.
I don't know.
Well,
Makes sense, but
yeah, I mean, it can affect both the sphincters because they're radiating all around those sphincters.
Yeah.
It depends where they're radiating.
I think the reason they came about is that if it wasn't an MRI guided brachy, then it was more likely to affect the sphincter, which I guess is kind of obvious.
Well, look, we've got to move on, David. I think that the bottom line for me here would be, first of all, to verify, because if it turns out that you're not a 4+4, if you're a 4+3, or even maybe a 3+4, then it's going to throw you into a different category of treatment.
Yeah.
I would be really concerned if you actually are a 4+4 as to whether it was necessary to radiate outside of the prostate. Where I've seen, this is totally personal experience, but I've seen too many guys who have not had extensive radiation and then their disease has recurred, where they might only have radiated the prostate bed. Doesn't mean it happens, but we've seen it.
Yeah.
And if you only did brachytherapy alone with 4+4, I would really want to fully understand why the doctor, in this case, Dr. Chang, was recommending it. He's a great doc. So if he can justify it, then I'd be drilling down on that. If it were me personally today, even with a 4+4, I probably would look at SBRT plus treatment to the pelvic girdle, plus some IMRT. So, and that's where I would be talking. Who did you say was the radiation oncologist at Mayo that you were talking with?
Frendel, FRENDL.
No, that's the urologist. Who's the radiation oncologist?
Oh, YU.
Okay, don't know him, but that's I'd probably be meeting with him and getting a better plan from him. Is he the guy that's talking about SBRT?
No, no, they don't do that. There's another local guy, John Kressel.
Yeah, they do it. Of course, they do it.
Oh.
They do SBRT at Mayo.
Okay, he didn't recommend it, but yeah, we haven't gone down that direction with him.
Well, I wouldn't want to be treated by a local guy, especially if you're a 4+4. If you're a 4+3, maybe, but I would be drilling down, examine those issues around radiation with Frendel. He knows enough, and he can direct you. And if
Yeah.
you're interested in SBRT, he can direct you. But I kind of would, I'd feel more comfortable if you were sort of more focused on where you were going to get your treatment. There's you got too many players in here, and it's hard to compare when they tell one says one thing and one says another. That's my own gut.
No, it's true. Very true.
And
So
go ahead.
I was going to ask if you were a vet,
If a what?
veteran.
Yes.
And I also wanted to agree with Rick that if you're actually are a 4+4 with one cribiform core, we're very sympathetic to wanting to minimize treatment, but I would want to be a little more aggressive than that. You could keep in mind what Dr. Wassersuck said if you're confronted with the idea of taking ADT, but fairly low level treatment only to the prostate worries me a little bit.
It does everybody. That's why I'm surprised Chang, who's a well-known guy, is only doing that with no ADT. I don't know. I mean, as Rick says, where do you throw your confidence? I've talked to a lot of people, and confusing.
I'm jumping in here. One variable, though, is you have a remarkably low PSA for someone who might have a Gleason score of 8 on multiple cores.
Yeah, that's not a good thing, and that would be a concern to me. That when you have a low PSA like that,
yeah,
you have 4+4, it can often be a signal that the disease is a lot more complicated than we see on the surface. So I wouldn't take that as a positive with 4+4. I'd take it as something that needs a lot more investigation and should be raised with Dr. Frendel. It should be raised with Dr. Chang. What do you make of the fact that I'm only a 4+4? That my PSA is currently, what did you think, 4.5, and I'm a 4+4.
And may not even be expressing PSMA if he's right that there's nothing lighting up in the prostate.
Yeah, it's possible that you don't express PSMA. It's a really good point. That's a great point, Dr. John. Really good point. I would talk to Frendel. I would go back to Frendel and say, look, just to be sure, why don't we do an Axumin scan?
What's it called?
Axumin, AXUMIN, Axumin. So say to him, why don't we do an Axumin scan just in case I don't express PSMA?
Okay.
And that would tell us if there's anything that we see with a 4.5. You would be getting a pretty good. You'd be getting a good chance of getting a result from an Axumin scan, because that is independent of expressing PSMA.
Okay.
All right, guys, got to move on. Okay.
Thank you.
Okay. All right. I've got too many pieces of paper here. All right. Let's start with Joel Blanchette, who you gave us an update last week, as I recall, General Blanchette.
Yes, and things have moved on since then. As you know, Dr. E believes that my colon cancer genes are driving my prostate cancer. Today, I met the televisit from Houston with a Dr. Quigley, who is trusted by Dr. E to determine to give me an endoscopy and a colonoscopy to see if I have cancer in my colon. That's going to happen on the 30th of April. So I'll be flying back to Houston on 30 April, 29 April. Dr. E herself is going to meet with me via televisit on the 3rd of April, a few days from now, to where she's going to report back to me on the 3rd Tempest test that she gave me in comparison to the one she gave me last November, because she's going to use a November one as the base, because Tempest has changed the amount of genes they test now for, I think, 523 genes. And she likes that report, and she wants to make sure that she has a baseline on me as we move forward. That's basically it.
Okay, so the gene that she's concerned about, as I recall with you, is MUYTH. Is that right?
Correct. And she briefed Dr. Quigley ahead of time. She was well aware of what the problem was. Yes.
Any other mutations that are bothering her?
Yeah, there's one. I think it's called TERT, she explained it to me, but it went way above my head.
Okay.
She gave an example of a tadpole, and the longer the tail of the tadpole, the longer your life is scheduled from your DNA. You'll live a longer life if you have a long tadpole tail. But this TERT gene cuts off the tail of the tadpole for me. So she was concerned about that. There's a special term for that, but I don't know what it is. I didn't understand. I never heard of it before.
Telomere shortening mutation.
A what?
Telomere shortening mutation, I guess. I don't know it.
Okay, that's it. That sounds right. That sounds right, Dr. John.
Joel, did you get all your hormone questions answered? Because we got Dr. Wasserson here in case you have any questions left about that.
Yeah, Dr. John is talking about luteinizing hormone and follicle stimulating hormone. And because mine were way above the range on my last blood test. And so I was concerned about that.
Did you get a referral to an endocrinologist?
No, I did not.
You might ask for one.
Okay. An endocrinologist, is that what you're saying?
Endocrinologist, the person who studies hormones.
Oh, okay. I've never seen one of those before.
Well, they will be able to tell you whether you need it or not. There are lots of things that can elevate them and lower them, and certain ADT agents act different ways. So if it's out of line and you're seeing a doctor, it's not inappropriate to ask for possible you need. You don't say, I want an endocrinology referral. You say, do you think I need an endocrinology referral? And see what they say.
Okay. All right.
I don't like to see a chronic ongoing high FSH level. I think that might be associated with more issues, side effects of ADT and other issues, heart, pain, bone.
You know, has Dr. E mentioned anything about the TP53?
Well, yes, the TP53 appears 4 or 5 times on the Tempest test, where it didn't in the past. It only appeared once on the older type test, but now it's like 4 or 5 different iterations of TP53. So she's concerned about 2, obviously.
So at GU ASCO, we had, I think it was Astellas or AstraZeneca, one or the other, was buying up space on the elevator doors to advertise some new treatment that they think they have for TP53.
Oh.
Remember, John? And the drug, I got to remember, and I wrote this up in one of the reminders soon after I came back, but I don't know if I can find it right now. What the actual drug was, and it was the drug that Pat, what was his name, who passed away, was looking at. He was in a trial for it. Got it. It was for it is azacitidine. Azacitidine, APR 246 is the drug. I've got a couple of links for it. And what I would ask Dr. E is whether this is something that could be in your future. There's because I remember it hadn't been on my radar, but then Ben remembered that it was something important. And let me see. I just put one link in for a clinical trial. And there's another link. And I'm pretty sure that was it. And I'm not really sure what it's got to do with Estella, but it had something to do with them. So that's just, it may be a bit of a rabbit hole to run down, but it may also be something that Dr. E knows a lot more about than any of us. But we were kind of surprised because as far as we knew, that there was nothing actionable for TP53.
Yeah,
Len,
Herb,
does this... Go ahead.
Herb had a problem with that too.
Yeah. Len, does this drug ring a bell with you at all?
You're muted, man.
You're muted, Len. Does this drug ring a bell with you?
Yeah, not the APR drug, but the azacitidine is a
Yes.
long-time chemotherapy drug.
Okay. So I think that this trial that came up, the first top trial, is this APR 246 plus azacitidine. If you click on that link for that trial that ends in 716, I think that's what that is. I think.
Okay. Thank you very much.
Okay. Yes, that's exactly what it is. And I think this was what they were, this is what whoever the farmer was pushing, because it's really unusual. All right. Anything else for Joel before we move on? Okay. I need to put this Joel colon endo. Okay. MUYTH. All right. We're going to go to Mark Valens, who sent me a note earlier on today. First of all, Mr. Valens, you're getting ready for Pluvicto tomorrow, are you not?
My second one. Wish me luck.
Wish you luck. You're looking, I will say, you're looking so much better than you were about a month ago, a month and a half. I'm so happy to say that. I don't know how you're feeling.
I can fake it pretty well.
Are you feeling any better? Seriously?
I was for a while, but this last week it's turned around. Not
Okay.
feeling so well.
I'm sorry to hear that. Mark wrote me and said, last week we talked about using bone strengtheners in moderation. And he wanted to know what was our reference for that. And, you know, we've spoken for many years about the fact that if you're on denosumab or zoledronic acid, that it's probably good to take a break after a good period of time because it has a very, very long half-life and it can have adverse effects, not just the ONJ, which we know about, the osteonecrosis of the jaw, but it can also have issues around making your bones a little more brittle and making them harder, but making them more brittle. And so the common wisdom that we've always heard is it's a good idea to take a break. The problem is I don't have a citation for that. And I reached out to John and to Len, and we came up with some issues, some articles about bone strengtheners, but neither of them really said much about how long you should be on them. So I'm going to throw this conversation out to anybody who would like to contribute about what they know about how long it's sensible to remain on a bone strengthener, whether it's zoledronic acid or whether it's the monoclonal antibody. I see Richard Wassersug's, well, his hand's up now and his microphone was on, so you're a very good person to start with.
Well, okay. So I'm sorry if it sound like I'm a one-horse pony here, but the research on transdermal estradiol for ADT shows that if you're using transdermal estradiol, you don't need a bone-protecting agent. It protects the bones. It is the same situation with women. Before menopause, they're less likely to get osteoporosis and a fracture. Go through menopause, and they have increased risk of a fracture. Estradiol is a natural hormone. There's already been clinical trial out of Australia showing that it is a bone protective agent. Now, I mean, if we've seen the way you are and you're in for Pluvicto, I'm not sure they would jump to your changing it, but on the other hand, they might decide why not. The long-term effects are there for the bone agents, and the longer you're on them, that is a standard like denosumab, the more brittle a bone's going to get. It gets really strong, but it gets like porcelain. So when it breaks on a hip, it really breaks. It doesn't have just a small crack. And that's a problem, the rare but serious hip fractures. But you might ask, if you're worried about being on the bone protective agents too long, why you couldn't go on a low-dose transdermal estradiol to replace the estrogen that would normally protect your bones. I'll stop there.
So that's something to discuss with Rahul when you speak to him next.
Yep.
How long have you been on a bone strengthener, Mark?
Almost 6 years.
Woo.
I think it says 3 to 5 years in the prescribing information.
There's been trials that have gone 8 years, and the bones just keep getting stronger.
Well, do they get stronger or do they just get more dense?
You might be right. Maybe that's the way it was written. But it's, I want to get off it, but then you got to be careful when you first get off it, because that's when you break bones. But so then you go on one of the phosphate things for a while to wean yourself off of the Extiva or Prolia.
Well, I think what you do, and Len will tell you because he's done it, is when you come. Are you on denosumab now?
Yeah, Extiva, yes.
Extiva. Okay. So what you do is, go on, Len, I won't steal your thunder.
Yeah, there was a paper on this, Mark, and I followed the paper with Dr. O, my oncologist. They said when the way to safely stop denosumab is to get a one-time infusion of zoledronic acid.
Yep.
And that has been proven to, quote, lock in the bone density gains that you made with the denosumab. How often are you getting denosumab shots?
Well, the Prolia had been once every 3 months or 6 months, but then they switched me to Exgeva, which is every month.
Every month. That was the original package insert, when it was approved. I'm not aware of many, if any, oncologists who are still giving that monthly. Most are giving it once every 3 months. And so the risk of...
Or 6 even.
Yeah, well, for Prolia, John, right? But I don't know about...
But that's what he's on, isn't it?
No, I'm actually...
he
I switched
switched.
to Exgeva. And
Apologize. Sorry.
all the dosing information that came with it says every month.
Yeah, but, a lot of times they come out with dosing information they use in the trial. Doesn't mean it was necessarily the right dose they should have been using. So I would talk to him about stretching that out to to 3 months. And, or of course, do what Richard Wasserstoke is telling you to do. Go on low. Richard, if he was to go on low dose estrogen, would he also have to take an ADT drug or a receptor blocker?
If it's low dose, I'm unmuted. If you're using the estradiol low dose to protect bone, then it can be just replacing the normal estradiol, so it'll be low dose. What we don't know, I mean, if you've had, you're already on lutetium 177. Have you had any bone fractures? And how are your PMSA scans showing particular loading of METs within the vertebra and the lumbar vertebra?
Well, the first one before I started Pluvicto, I had a whole bunch of METs that showed up on my spine.
And were they painful? Were they symptomatic?
Well, one was, and we zapped that one, and that took care of the pain.
So I mean, Len can respond to this. I'm guessing that they're blasting you with bone protective agents because they're so afraid you're going to crush one of those vertebrae. So I think they're maybe overreacting, but you don't know. And are you able to exercise at all? And are you exercising at all?
I am exercising some, not near as much as I was. I got so little energy. I work out for 15 minutes, and boy, I'm shot for the rest of the day.
But are you walking or jogging or something that loads?
Yeah, and I do step up exercises, and I use some bands and some weights.
Okay, so I mean, this is their focus is on skeletal related events. I've always loved that term. It sounds so simplistic. They don't want you to crush a vertebra, but it's SRE, skeletal related events, and their focus is on that because that's where it gets a big crisis if you crush a vertebra. But you can ask about estradiol because I don't see any reason why, after you've been so loaded with Prolia and so forth, I don't see why you'd have to continue it when you could go over to just replacing your lost estrogen.
Okay.
But I'm not a doctor. I'm just a bench scientist.
Well, I'll see what Dr. Raul Aguilar says. I haven't brought it up with him.
Right. So that's exactly what I was going to say. I definitely would raise this issue about in a sort of package conversation about bone strengtheners that you've been on for so long. What should you be on? What shouldn't you be on? And should you be using estradiol for your bone health? We're not right now. I mean, you could, But right now, we're not talking about estradiol in place of an ADT
Lupron.
drug.
Yeah, Lupron's the only ADT drug I'm taking out of it.
Right. Right. So, there's another issue too, although I don't think he would do it. But are you on darolutamide or?
It failed. It wasn't doing any good, so we
Oh, that's
stopped it.
right. That's right. So the only thing you're on is the ADT, right?
ADT and Pluvicto.
And the Pluvicto, yeah. Well, you can't stop the ADT then.
And the chemo failed also. I took what 2 or 3 chemo things, and it didn't stop a thing.
Yeah. So maybe just talk with him about using a little estradiol to help your bones and coming off the bone strengthener.
Yeah.
Anybody else want to say anything to Mark on this topic?
Well, thanks, guys.
Good luck tomorrow.
I hope this one. I didn't have any reaction to the first one, and I hope the second one will be the same. But I keep finding people to say, well, the second one was worse than the first, and the third one was worse. So I don't want to. I'm not opening up that possibility yet.
Okay. Just make sure you stay away from Anne for a couple of days. That's all.
Yep.
Okay. All right, guys. I'm going to move right along, and next up is Steve L. Mr. Lodge, this is a good transition because we were talking about Pluvicto and you wanted to talk about Pluvicto. So what's on your mind to ask about?
Yes. Well, first I was going to note what you already said, that it was approved prior to chemo now. And secondly, many treatments are more effective for certain types of patients with certain expressions than others. And I haven't been able to see that for Pluvicto.
It's there.
So I'm wondering, over time, I'm wanting to explore that some.
Okay, well, now I'd have to go back and dig it out. But there are mutations that favor Pluvicto, and there are mutations that Pluvicto does not favor. So, and you guys may have to help me out because I'm doing this from memory. But what I think is that if you have BRCA or ATM, that you do well with Pluvicto. I think that's right. We know that if you have the tumor suppressor growth mutations like TP53, RB1, NBN, and P10, that you don't fare so well, especially if you have at least 2 of them. So the gents that we have seen over the years, first of all, that is been established in research. That's not an anecdotal observation. We can tell you that the guys that have had at least 2 tumor suppressor growth mutations have not done well. We've seen it. And if they've had 3, they don't get a lot out of Pluvicto, if anything at all, from the beginning. We do know that some of those HRR mutations, I don't know why, seem to produce better results. That's about the limit of my plebeian knowledge. So I'll throw it open to anybody who can throw more light on the topic. Len or Dr. John or Dr. Wasasug, anybody else want to talk?
I also have RB1 as
Right.
maybe causes a poor response to
Right.
lutetium.
Right.
And I have TP53, which you mentioned already.
Right, and RB1. Yeah, I mentioned RB1, TP53,
Oh, you did?
P10, and
Okay.
NBN. And those are all TSG mutations, or TGS. I always forget which way it grounds. Could be TGS.
Tumor suppressor gene.
Yeah, TSGs.
And I've got ATM as possible better response to
That's right.
lutetium.
Yeah, ATM and BRCA1 and BRCA2, I believe. And I don't know which other HRRs.
Rick, from GU24, ASCO 24, there was a paper that I presented to the group last year that said there's significant cross resistance between PARP inhibitors and lutetium. So that if patients had a PARP inhibitor first and then they had lutetium, they didn't respond at all.
Okay. That's helpful.
But I don't know anything about specific gene mutations.
Yeah, no, the gene mutations have definitely been reported. The other thing that we've seen, but it's very tenuous, but it was in a small study and it just sort of reported better results, is that people had more success with chemotherapy after lutetium than before. That was a study out of McGill. I've got that poster. But I think there's going to be a lot more coming out. I mean, now that we know that we can use Pluvicto earlier in the disease cycle, we're going to see if all of a sudden chemo starts doing wonders after you've had lutetium, then that'll kind of confirm it. But I don't think there's enough research right now. What mutations do you carry, Steve? Do you know any?
Very few. Based on, yeah, I'm probably going to have some new testing within the next few months, but from what I've seen so far, very few mutations.
Speaking of which, any progress in getting to see Dr. Fong?
I've seen him on Thursday.
Oh my gosh. Oh my gosh. Please give him a huge hug from me and tell him, you tell him, mea culpa. I owe him a letter. I owe him an email. Yes, I do. Oh my gosh. Oh, I'm so excited for you.
Yes, I think it'll be a good move for me.
Oh, he's great. I love him. He's so great, and he is probably amongst the very best immuno-oncologists in the country. So, oh, that is so great. Oh, I'm so happy for you. He's really special. He's really, really special. Ask him. You won't remember him. I'll send him a note. Go ahead.
What's his name, guys?
Fong. Larry Fong. He's on our advisory board.
Oh, great.
And he was the original principal investigator for Provenge. So he's been around the immuno-oncology space in prostate cancer longer than pretty much anybody. So anybody else want to say anything about Pluvicto or add anything on Pluvicto? Yes, I see Jeff Marchi has his hand up. Sorry, Mr. Marchi.
Yeah, a search I did shows that FGFR, MYC, and CDK12 alterations correlate with reduced PSA response and indicate lower treatment efficiency with Pluvicto.
Okay, so the bad guys are Mick, And what were the other two?
FGFR, MYC, and CDK12.
CDK12, right. CDK12 is a bad actor. That's right. I didn't know about the FGR.
GFR. FGFR.
I didn't know about FGFR, I didn't know about MYC. And
TP53 is linked to aggressive prostate cancer phenotypes and poor treatment outcomes as a result.
Right. So we know, we've already said TP53.
Yeah, I know, but that's the reasoning why. It's just a little bit different than the just poor response.
Right. So, but we do know that the tumor suppressors and MYC, and there's some other stuff going on with MYC right now, I think, with the mevrometostat. Somehow involves that EZH MYC pathway. And we're excited about it, mevrometostat. I actually noticed just today that a doctor we do a lot of work with for renal medullary carcinoma, who is at MD Anderson, is also looking at that same pathway to try and address renal medullary carcinoma. That EZH pathway, I saw it in his research. Okay, well, that's a good one. We came up with another one. Mick. Okay. The guy who has been researching MYC forever and a day at UCSF. I ran into him at GU ASCO. Davide. I can't remember his last name. He's Italian. And he recognized me and I recognized him, but he's been doing this MYC research going back to probably 2010, 11, 12, something like that. I don't think he's come up with anything yet, but there you go. All right. I don't know, Len, you're posting a lot of stuff. What should we be taking out of that in the chat window?
Well, the last two are really part one and part two. But that is the poster session that I reported on earlier, well, last year and then just earlier verbally, showing that prior PARP inhibitor therapy to lutetium doesn't bode well for lutetium. They don't respond. There's cross resistance. The other one goes back to Joel, that drug that was mentioned to him is a TP53 reactivator. That's the one that was given with azacitidine, remember?
Yep. Okay.
Thanks, Len.
Thank you. Thank you. There will be a test, General. All right. I'm moving along here. And next up is Dr. Wassersug to talk to us more about E2, and then after that, Jimmy. So
why don't you let Jimmy go first? Is that all right?
Well, we could let Jimmy go first, and then we could come to you. Yes, we don't have anybody else. Well, we don't right now, but we'll come to you. But I will check in after Jimmy and before we come to you if any of the people that arrive late, since we have extra time, so we can talk to them. Jimmy, keep it relatively short. We don't want the $5 version. We want the $1 version. Okay.
No, I'll have to work on condensing it then. Next week. I don't think I can. It's complicated. I'm not sure I can condense it as much as you want me to.
Well, I think you're going to have to, even if it's next week, because we can't.
Next week I'll be prepared to condense it more.
And Jimmy's having a bad time. Let's at least try a little bit, okay? Rick?
I'll come next week. I'll be more concise.
Because we already put him off a week.
Jimmy, you're welcome to take. We've got 25 minutes. We've got or a little more, and we've got Dr. Wassersug
Okay.
and possibly a
All right,
couple of
fine.
other people.
Fine.
So why don't you go for it, and then
Yeah.
we'll stop you. But what I want you to do is just try and be concise. Try and be concise.
Yeah. Okay. Well, I don't have anything to complain about because, cancer-wise, I'm in a good position. I've been for a while. But pelvis-wise, no. I'm one of those guys that got surgery and then was advised to get radiation, ADC, abiraterone, and chemotherapy immediately afterward, which was a clinical trial that had some high hopes, but in retrospect, probably didn't have much going for it. What it did have going for it was that I was left with permanent incontinence. It required as far as I'm concerned, required an AUS insertion in 2021. And since then, I've had nothing but problems in that area. The urologic surgeon says it's not possible that it was caused by the surgery, but of course, I don't know that that is so. What I do know is that I've had orchitis, epididymitis, multiple recurrent high fevers, redness, rash, swelling, and landing in the hospital last year. I got a hydrocele early this year, which is a fluid-filled sac in the scrotum. I had surgery to have it removed on 28th of February, and I could not pee afterwards, so I had to be recatheterized, which was very painful. I kept the catheter in for a while, but when I was removed, there was no way to reactivate the AUS because the swelling was so intense. So this has been off and on. I had urinary retention. It was very painful a couple of times to go back. It's just been a nightmare. Finally, they're able to deactivate or completely deactivate the AUS, which got me the catheter out of me, but then left me 100% incontinent, even more than I was at necessitated sphincter, meaning that every time I get out of a chair, I basically peed full on for about 5 to 8 seconds at least, maybe more, plus leaking at night, which I didn't even do when I had incontinence before. So when you don't pee on your own for 4 years, I suppose that's what you're left with, is a complete and total incontinence. So for anybody who's, and now today is the good news. I felt finally the swelling went down enough. He was able to reactivate it. The urologist returned from his vacation to Morocco. I don't think he was negligent. He had to go there anyway. He was having a nice time on vacation, but also I had too much swelling to do anything about it anyway. The swelling did finally go down, fortunately, quite a bit in the last couple of days before he got back. And then today he was able to not only reactivate it, but importantly, that I could reach in and get it. But the tab for the AUS had migrated behind the incision where the hydrocolectomy was, and was very difficult to reach. It's still hard to reach, but it's possible. So what I have now is I have continence. So the good news cannot be overstated. I mean, if any of you have had even mild incontinence, you know it's a pain in the ass. But when you have heavy, it's a nightmare. And it's not a nightmare. It's an ongoing, constant thing. And so now that that's gone, my only message is, if you ever have heavy incontinence and decide to get an artificial urinary sphincter, that's great. But if you have any surgeries down there, if you have any swelling down there, if you have trouble down there, you may be put in a position where that thing has to be rendered non-functional with the catheter, and then swelling will have to subside before it can be reactivated. That's what I experienced. It was no good. It was no fun. It was hard. Looking back, I think I was over-treated somewhat, but I can't know that. And the thing is, I can't sit here and complain. You guys are at Pluvicto. You're in all kinds of stages of advanced disease. I have extremely high-risk prostate cancer that has not recurred in 4 years this month since full return of testosterone. So I don't have a single complaint. But if I had a complaint, I would, because this was admittedly a difficult time, and I felt kind of helpless at times. I've been to a lot of different urologists about this, and I never felt like I got any kind of good answer where the redness and swelling. My penis is still very swollen. I couldn't even use condom catheters because it was so swollen around the base, it would just fall off. So there would seem to be no answer along the way. But, you know, we all have our problems. So I'm just kind of giving that as points of information more than any complaint or any, you know, plea for sympathy, because I don't line up for that anyway. So is that concise enough?
Great job. Dr. John, anything would you like to continue this conversation with Jimmy, since you are, you wear the same T-shirt and
Well, Jimmy got his device, I think, just a little bit before I did. We've both had our complications, but he's just had a terrible time with this thing. I really feel for you, Jimmy. I'm really glad that you got the catheter out and that you can get your hands on that switch now. And I hope that swelling continues to go down.
Thanks. I got a lot of experience with some really, really good aircraft grade underwear. Not that it bends with the model on the package. The one with the plain label.
Jimmy,
yeah.
how's the today, since you saw the doc? How have you managed with the AUS, turning it on, turning it off, and what have you?
It's hard. It's hard to reach. I have to reach behind the swelling and kind of push it up and feel for it, and it's located just devilishly right around the incision. So I have to grab it and squeeze it, and I'm grabbing and squeezing it at the point of the incision. If I press hard enough and take my time, I can press it over to the left where it used to be. It used to be very conveniently on the left. Again, it migrated after the surgery, and as if it was trying to hide from me. And now I'm gently pushing it back. I can work it, but it's difficult, but well worth it.
Can you pee through the thing without unlocking it?
Oh, no, sir.
I can with mine.
Can?
Yeah.
Wow.
Can't, huh? Okay.
You're not supposed to be able to do that. Do you
Well, no, I know you're not supposed to be able to do that. It's probably not exactly the right size for me, and of course that comes with the cost of leaking.
Do you leak? Do you leak?
It would, yeah, but it would be nice for you if you could pee through it like I could, because then you wouldn't have to be digging for that switch.
Well, you pick your poison. I don't want to leak either.
Right.
But you always leak after you pee for a while anyway. I mean, for 45 seconds of mild leakage. These are all compared to being incontinent. You know, I'd love to have it the way it was when I was 20. Get up in the morning, pee for 2 minutes straight, shuts it off like a tight valve. Those days are obviously past. But my penis, I mean, okay, I'm not going to complain. My penis, I had this quite above average, very well functioning penis. Now it's about this big. It's got a little cap on it. It disappears under the gland. So it's as if I'm uncircumcised, which I'm not. Hard to keep clean. And when I would pee, you know, if I could not even get it out of there. So the pee goes everywhere. It was really, really tough. Now I can kind of get a handle on it again. I can fold it back. It's better already. But it's been a little rough time.
Jeff Markey, what are you?
I was just wondering, they've got this technique called ProAct, where they put a couple of balloons in where the prostate was, and they can enlarge or reduce the size of the balloons to reduce or increase the amount of leaking. And I'm just wondering if you guys have heard of that, and if maybe that could be used along with what you have. You can leave your AUS on and just let that work. I'm ProAct. Have you heard about it?
No idea. I've never heard of it.
It's I've heard a couple people that have had it put in, and it's worked quite well. Stopped their leakage completely. You might want to look into it. I mean, if your AUS is not working right, and that could be put in behind it and mostly resolve the problem. It
works fine when I'm able to access it, but I've had so much swelling down there and other problems. I think
you know, just something to think about. PROACT, PROACT.
I'm just one of those people that have had a kind of a problem that has been a compounding number of things. The sum has been more than the total, more than the sum of the parts has been the outcome, and really very very unpleasant. But like I say, there are definitely worse things, and today I'm feeling quite a bit better because of this. Just beware. And you will be incontinent to the point that you were when you get radiation. In my case, they told me that too. So when you get IMRT, your incontinence is going to freeze at that point and stay where it is. They were absolutely right about that in my case.
Jeff, can you just put the name of that PROS, whatever it was, in the chat window, please, when you have a second?
PROACT, but I will.
Okay.
Jimmy, what about a suprapubic catheter? Is that something you would ever consider?
Yeah, what does suprapubic mean? Is that condom catheter? Is that the same thing?
No, I mean, well, probably Dr. John can explain it better. My understanding is a tube inserted directly into your bladder that empties into a bag.
Oh, that. Yeah, no, I didn't look into that. I was trying not to get any more penetration. You know, I've had a lot of infection down there, and I've had a couple of surgeries down there, and I am just, I'm loath to cut into that area anymore. And I know it's not in that precise area, but I was holding out on anything like that. And also to have another surgery to reopen it to reposition the AUS. Fortunately, it looks like all that's not going to be necessary. So I may get off relatively easy. But thank you.
Okay.
So, any other questions for Jimmy? If not, I'd just like to check with a couple of people, and then we'll go to Dr. Wassersouk. Ed Lefrancois, excuse me, Ed Lefrancois. Did you need any time later?
No, I was just going to give a quick follow-up. I did get a call today from Yale, and I'll be meeting with Dr. Joseph Kim on next Wednesday. I gave 2 names, and I researched them both. And Dr. Hurwitz is more into kidney cancer,
Okay.
whereas Dr. prostate. His expertise is in prostate. So I'm Dr. Kim, and we're meeting with him next Wednesday. And I'm keeping my PSMA PET scan at MSK for this Thursday. They said that would be okay.
Dr. John, did you want to comment?
No, thanks. We've been going back and forth, and I think this sounds like a good idea.
Oh, great. Okay, I'm really pleased that you've been in contact with Dr. John. God bless you, Dr. John.
Thank you.
That's thanks for helping Ed out, and Ed, we're eager to hear what Dr. Kim says to you, and this may be a little more convenient in the long run.
It will be quite a bit.
Okay. David Opp, anything for you?
No, nothing for me.
Okay. And Michael McCabe, anything for you?
I'm doing good, guys. I'm just taking an Orgovix right now because if you remember, I had some problems with, actually, was it Firmagon? And I forgot the other medication I was taking with depression. But anyway, the last test I've just had, PSA, was 0.2 or something like that, where it's right at that point where you need that other test because it's really low. So whatever that's called, you guys. And otherwise, pretty good. I am having some trouble with from the radiation with SBRT I had with bowel stuff. So I am going to have some tests for that. There is a possibility I may have to do hyperbaric therapy for that. Other than that, like I said, cancer-wise, everything is going really good. I'm very happy with that. So that's kind of where I'm at. Guys.
So you're only taking the Orgovix now, and
it's going to be reevaluated, Rick, like in another month. It's going to be reevaluated.
And what did you say about a hyperbaric chamber?
Yeah, what is that called? The bowels are irritated and whatever, cramping and diarrhea. I forgot what the name of it is.
Radiation proctitis.
Yeah, yes. It's highly suspected I have that, but I've got to have some. Again, that's going to be next month down in Madison, Wisconsin, at UW, where I go now. I'm going to be running some tests on that to firmly diagnose if that's what the issue is, and then the recommendation they would recommend is that hyperbaric therapy.
Okay.
So that's where I'm at, guys. Otherwise, I'm doing all right.
Okay, good. I'm glad you're doing all right. The chair is yours, Dr. Wassersuch.
Thank you. I know you're getting to the end of the hour here. Most of you many of you may already know this. I have been using myself transdermal estradiol high dose for ADT for well over 20 years. And a gentleman who has been on these calls before meant to join me, and he contacted me during this session to say he somehow couldn't get in. But his name is Paul Shellhammer, and he is a prostate cancer patient. Prostate cancer.
Yeah, he was on last week. He spent a lot of time with us last week.
So Paul was planning on being here as well because he too has been on transdermal estradiol for a long time. And what's happened, and many people have heard about this, is that research is coming out of the UK showing that this is as good for cancer control as drugs that we're talking about, like Lupron, Orgovix, etc., but with better patient quality of life. What is particularly intriguing is that it is also, depending on how you use it, about 100 times cheaper than Orgovix. So a couple of new things I can report is that although it is not an approved treatment in North America yet, we're hearing, and Dr. Shellhammer can confirm this, that with proper letters, physicians have gotten the drug companies to cover the insurance. And why wouldn't they? Because if they have to pay for Orgovix or pay for transdermal estradiol, they might as well pay for the transdermal estradiol, which is that much cheaper. Now, Paul Shellhammer and I and another patient are going to be presenting a poster at the AUA, the American Urological Association meetings next month in Las Vegas. If any of you are going to be there, I'd be happy to meet with you. What is important to get the punchline is we really don't know to what extent patients would be interested in having this option. So with Paul Shellhammer's support, we are having an ongoing survey study. It's an anonymous online questionnaire with Rick Davis's support. He's posted it on the website. I encourage you, not Rick, I don't know if you could repost that. That would be really appreciated if you could repost it. And
so let me just say, we haven't posted it on the website because we don't really do that so much. We put it in the reminder 2 weeks ago. I didn't put it in. We will put it in again. Why don't you put the link right now in the chat window, and then that will also go into the recording.
I can't get to it immediately. Sorry. I have to dig and bury it. I don't have it on reach on this computer. So but I was going to say, if you haven't filled it in, you get it, please fill it in. But also, and this would be, I'd love to see it go out, Rick, to your active surveillance people. I'm not just interested in hearing what.
No, we will not send it out to the active surveillance people. Absolutely not. And the reason being is that at AnCan, we keep our groups separate.
Okay.
Let me finish. and then you can rebut me. We keep our groups separate. So we have low, early, low, intermediate, active surveillance.
Right. So
and those, that.
Go ahead. Sorry.
Thank you. And that is for men with 3+3, maybe 3+4 disease who have not yet considered any treatment. And we don't talk about radiation or surgery, and we certainly don't talk about ADT or the need for ADT in that group. We try to protect those guys a little bit, and they don't want to talk about it. We don't want to give them any additional anxiety. As Dr. John will tell you, he's been in there. There is a huge amount of anxiety in that group, even though it may not sound right, there is. In the low intermediate group, we may talk about actives, we may talk about ADT, but usually it's only in the context of no more than 8 or 9 months. If it's more than 8 or 9 months, they come into this group. So we absolutely don't want to raise issues around ADT in the active surveillance, and I would have to speak to Dr. Perlow about how he feels about it in the middle group. In our group, yes, we'll post it again for you, for sure.
Thank you. Let me just say this survey is not about people's side effects. It's about having, if you in the future might ever need these treatments, and there's various options with various side effects. There are these side effects versus those side effects. And it's important to us in the design of the study and the underlying hypotheses, we can explore and compare patients who have been on these drugs versus patients who haven't been on the drugs. So it's really one way or another we can reach.
We don't want to give them we don't want to put it on their radar.
That they may need these drugs in the future?
That's correct. We don't want to put on their radar, if they are in low, intermediate, early active surveillance with 3+3 or 3+4, that they may need ADT in the future. These men are already very, very anxious.
And a
lot more anxious than you would give them credit for. And you can come in and listen to one of the active surveillance groups.
So
it's not a discussion that we will raise at AnCan. Period, paragraph.
All right. So also let me just say that there's published research that shows that patients who are aware of their potential treatments and the side effects actually do better. But that's not what the questionnaire is. It's all of a 10-minute survey. But patients who do not know ahead of time have significant less self-efficacy in managing the side effects. So we're not trying to teach them about the side effects. We're not going to. The questionnaire does not suggest they're on it, but it does. But we need to know before people go on these drugs who would prefer this versus that, and that's a particular patient group.
It's not even on their radar. It's not even on their radar. What is on their radar right now is they are trying to stay on active surveillance for as long as they can. Once they know they've got to move off of active surveillance, then maybe we talk to them. But for these men with 3+3 disease, there's absolutely no reason at all to raise androgen deprivation therapy, because if they're at 3+3, they don't have a risk of it metastasizing and needing ADT. If 3+4, they may have a very small risk. So I would I'm not disputing that if you know what your treatment is before you encounter it, fine. But right now, these men on early, low-risk active surveillance, it's totally remote. And with 3+3, as long as they truly are 3+3, it will remain totally remote, because it doesn't, with 3+3, we know the disease doesn't metastasize. And most of our guys are on 3+3. So that's why by all means, maybe you can get ASPE to do it, but we're more protective of our guys, and we we will not raise that.
Who is
They don't
asking?
want to discuss it. I mean, if somebody raises what is androgen deprivation therapy, we tell them not a discussion for this group.
Okay, it's your group. Thank you.
Well, it's AnCan's group, and what we're concerned about is the men who attend, and we have a good handle on the men who attend, on both low risk active surveillance and low intermediate, and we don't believe that those men want to discuss androgen deprivation therapy or E2 or anything else early in the disease cycle, unless they have to, in which case they're probably going to be in the high risk group. A few may talk about it in low intermediate if they're required to go on it for a very short period of time. Gary Peters, go ahead.
Rick, what is ASPE?
ASPE is Active Surveillance Patients International. It is a group that started around 2017 or 2018 for men on low risk and low intermediate active surveillance.
Thanks.
And they've done very well. They're a good group. Howard Walensky is very active in that group, as are many other people. But, you know, that's who it is.
Thank you.
Well, thank you. That's my report.
Thanks. And, you know, how many responses? And you said you started to do some early analysis. What are you finding?
I'm finding that, well, we have about 300 people who have taken the survey so far, and they overwhelmingly want the option. I had in the comments a lot of questions about, does it help with this or does it help with that? And if people have questions, I stuck to the side effects for which we have hard data, but there is secondary data on sleep improving, lower levels of seemingly depression, probably less evidence of cognitive impairment, less daytime fatigue from various studies pulling them in. They weren't all from the patch study. So all of it shows that what's already been published, what's already been reported at the scientific meetings is good, and there's additional data to show that it's probably even better than what's been reported so far.
Okay, we have 3 hands up. Len.
Yeah, Richard, last week there were at least 2 or 3 guys who had a history of using estradiol or currently using it, and a couple of them, I believe, said the patches were inconvenient and they were using injections or some other form of parenteral,
right,
infusion.
One patient, and I don't even know who it is, who's gone over to injections, and it actually is a possibility. Using a gel product or a cream, the gel can bring the cost way down below what the patch protocol had in the UK. And I use a gel product and co-author with myself, and on the poster will be at the AUA with Paul Shellhammer, also use the gel product. It is more convenient, and the questionnaire looks at those type of things. If you had this type of transdermal estradiol versus that, if you had injections every 3 months, you don't have to get a lot of blood tests. But if you use this product and you may have to get a blood test more often, what do you care? Those are the type of questions we ask. So, but it's so important that we get people who are not just on ADT, but maybe going on ADT. And I agree, Rick, you made a good case. It doesn't have to be people on active surveillance, but we'd love to get patients who are not already on ADT, as well as those who are on ADT, to find out ahead of time. And I'll give you an example. We do ask, for instance, about breast development. That comes with estradiol. We also ask about hot flashes. And generally, the patients who may not have had hot flashes may not think they're particularly concerned until they have hot flashes. So we want to know how much the exposure to the ADT is influencing the acceptance and interest in the various treatment options. All of this is in prelude to, in advance of going to the FDA and making this available and licensing it in Canada. They are now going forward in the UK looking for what's called repurposing of the patches, but they are working within the confines of the patch protocol. We'll be showing in our poster at the AUA that the different types of patches, different products on the market, the prices are all over the place. The patch people, unfortunately, picked the most expensive patches for their study. So these are the sort of things that we're looking into, and we need to find out what patients are interested in, because that is the barrier to getting it approved and making it available. So that's. There were some other hands up. I'll take other questions if Rick will allow me. We have the time.
Sure, Jack.
Just it seems to me logical that this is a patch would be best utilized in doublet therapy as the first way of seeing how effective it is and desirable it is, and then segueing into ADT alone for those who are only using ADT alone, because it's too risky to use in lieu of ADT alone in people who, we know where we are, what we're doing in terms of, the risk of
So it's
I'm sorry, go ahead, Richard.
No, it's a very good question. And in fact, there's been 3 studies now by the patch team. The first one was looking at non-metastatic patients. The second one was looking at metastatic patients. And the third presentation that they just recently gave was looking at doublet therapy. And they showed that it was just as good for cancer control with doublet therapy. But it was interesting because the study ran for 14 years. And doublet therapy wasn't around when they began it, so they had to, add that arm. But it looks very good as any ADT agent in collaboration with any of the RPs, ARTAs, whatever you wish to call them. I'm endorsing what you're saying.
Dr. Jack, any follow-up?
Follow-up? No. I'm just curious, where it's being used and what context it's being used, and it just seems logical that we start with the doublet approach first and then working way backwards.
We're not. It's not to the point where it's being used in a standard clinical situation. The trial has just been completed a few months ago, and they're just now reporting the results. There's overall long-term survival results, and it's actually they're 2% better, not statistically significant, than drugs like Lupron. Better survival.
So what's this Alex Bies, B-I-E-S-E? I was just looking at it. He did a transdermal estradiol plus ARPIs demonstrate comparable PSA response to LHRH in metastatic prostate cancer. That's a study that just came out February 14th. I just Googled it. And
was that at ASCO? Was that a presentation at ASCO?
BS. No.
That was Duncan Gilbert.
Yeah, and the GU Cancer Symposium 2025.
That's part of the PATS report. That's
okay. Yeah.
Other questions?
Michael McCabe.
Rick, I just want to thank you for letting me get in here at the end. I came in late. I wanted to get here sooner. It didn't work out. So thank you for taking time and letting me come in. Appreciate it.
Oh, okay. No questions on estradiol.
Myself, I don't think it. I don't know if you guys remember, but Gleason 7, Gleason 8, in a couple lymph nodes right around prostate pelvic area. So I don't know. It's just getting me worried that what am I doing, the wrong thing then or what? I don't know. It makes me think I don't know. So, I don't know what else to say about that. And I'm not trying to, and I'm not cutting anybody down for it at all. I'm just.
Oh, okay. No, I know it gets complicated. It's more options. This one's been around a long time. It has it definitely has a lot of pros, probably have a lot more pros than most people have ever recognized. It has some cons as well. But it's all about quality of life, and Dr. Wassersuch will assure you that he feels he's had a better quality of life than if he was on an androgen deprivation drug.
Okay.
That's fair enough to say, isn't it?
Well, this is androgen deprivation. It's just breaking the link from the gonads to the hypothalamus to the pituitary at a different place in a different way.
Right.
But my answer personally is that my brain works better on any gonadal hormones than on no gonadal hormones.
Okay. Well, I'm interested in a way, but that's all I can say.
Gary Peters.
Richard, with a high dose estrogen, what happens to your testosterone?
It depresses it. This is a form of androgen suppression therapy. Your body normally sends a signal from the gonads through the testosterone to your brain, and it tells the brain, do we have enough or don't we have enough? But if you give it overdrive, if you take guys who are bodybuilders and they're hyping up on anabolic steroids, they will suppress their own gonadal signal to make testosterone. Similarly, you can go on high dose estrogen, and the part of the brain that regulates this doesn't care which gonadal hormone it is. It says we've got enough gonadal hormones, shut the system down. So it is a androgen suppressing drug at high dose.
I never knew that. Estrogen will shut down what? LH, FSH? What does it shut down?
Yeah, you shut down the signal from the hypothalamus to the pituitary. So it shuts down the LHRH LHRH signal from the hypothalamic pituitary link. It's high dose estrogen will do it. High dose estrogen, testosterone would do the same thing. Any high dose gonadal hormone, the body says we have too much gonadal hormone, make less of it.
I just didn't know that estrogen can shut down testosterone synthesis. That's new. I can understand it shutting down the estradiol.
I'm in Canada. I'm in Canada. It's a lovely Canadian story. The guy who figured this out was a Canadian, a guy named Charles Huggins. Because the first thing he did was castrate people, and he got a Nobel Prize. Only Canadians get Nobel Prizes for castrating people. But then first, a chemical drug for controlling prostate cancer was diethylstilbestrol. It was a synthetic estrogen. And the problem was they took it orally, and it caused blood clots. The important thing now is we're looking at it taking it non-orally, or parenterally, as Len said. That is, it could be injections, could be through the skin, but not orally. And then you don't get the surge of upregulation of the blood clotting system, so you can shut the system down. But that was a popular drug before they came in with Lupron. That was the drug they used, was diethylstilbestrol, a synthetic estrogen and an oral estrogen, and a dangerous drug. And as an aside, the transsexuals, because it's so damn cheap, still use it. And they use it in third world countries. It's a tragedy. So if we can make the transdermal estradiol available at a very cheap rate, we could actually be offering hormonal therapy, androgen deprivation therapy, to countries that can't afford it, where the guys still have to either go on diethylstilbestrol or get an orchiectomy. That's why this is so important, why we need more people to take the survey. We need people from all different parts of the cancer spectrum to take the survey to get adequate numbers. Rick, shut me up. Tell me I've talked enough.
No, it's really interesting, and your time has finally come, and you've waited long enough for it, and so God bless you. I hope you understand that the reason I will talk to Dr. Mark, or you can write to Dr. Mark, Perloe, Perloe, Perloe at AnCan.org, and ask him how he feels about putting it in his reminder, because it's really up to him. I don't think he'll have a problem with it at all. But I just don't want to bother the guys. It's I don't want to upset those gents in the active surveillance. It's tough enough as it is, and we walk a bit of a tightrope. So that's the reason why we don't want to do it there. But maybe you can get the ASPE guys to push it out.
I appreciate the lead. I will look into it.
Talk to Howard. I think you've already asked Howard about that, right?
No, I haven't talked about it.
We haven't. We'll talk to Howard. Ask Howard and see if they'll do it. But we just don't want to do it. By the way, guys, Wednesday at 7:30 Eastern, 4:30 Pacific, Dr. Liss is going to do a half-hour presentation before the active surveillance group, and he's going to talk about microbiomes in your gut and the study that's going on there. where we think that if we change the microbiomes, it may have an impact on your disease progression. There's some interesting work going on. And the list method is very interesting. It's very simple. It is 30 different vegetables a week. And that's what he says will get you the right result. Now, I've only got up to 22. That was the best I could do in a week. And that's good going. But if any of you can get up to 30 a week, then let me know. But it's a very healthy diet, 30 a week. And come in on in this room, 4:30 on Wednesday, 7:30 Eastern, and you'll learn a little more about that. And he's recruiting for a trial. Unfortunately, it's only for 3+3 men. But that isn't going to change the information he puts out. All right, everybody. Is it soup yet? Okay.
All right, it's soup.
It's soup. Thank you very much. Thank you, Dr. Wassersup, for stopping by again. Much appreciated. And we will see everybody. And I will tell you, if you didn't listen to it, Richard, last week, we had a great session with Dr. Shellhammer last week. It's worth listening to. Okay. Good night, everybody.
Good night, everybody. Night night.